Hello, everyone. I hope you can hear me now. And we are going to start our discussion of the counseling cases. Just to make sure that everyone can hear me clearly, can you please write in the chat box that you can hear me and can see my screen? Okay, good. So we can start. We have 5 different cases to discuss. As much as possible, we'll try to cover all of them today. But if it is not possible, then perhaps we'll try to cover as many of them as possible. So some of you had expressed your interest in doing the role plays, and I have noted your name here. So let me just have a look, and then we'll start with the role plays. If all of those people are present today. Okay, the first one we have here is for the migraine case, and Salma had expressed her interest in doing this case. If you are present today, perhaps we can start with you. You can unmute yourself and we can start the discussion. Okay, let me check if the others are also present. Junaira Anwar. If you have joined, can you please let me know in the comments, in the chat box? Junaira, Usma Iftikhar, Saima Farouk, and Salma. If all of you are present, please let me know in the chat box. Can you please write and let me know so that I can start with one of you with your preferred case? Okay, who wants to start first? Who wants to do the first role play? Okay, Usma.
Yeah. Hi.
Hello. So your preferred case was AAA, right?
Yeah.
Okay, so we can start with the AAA discussion.
Yeah.
Basically, how we are going to do today is, first of all, this is not a teaching class. This is an interactive session, so we'll be having discussion after you finish, and I'll try to give you my feedback on how you did. I'll try to note down the points which you may have missed, or which you could have done in a better way. You will have 1 minute to prepare. That means to read this team. In the exam, you get 2 minutes, but I'm only giving you 1 minute just to make sure that in the exam you have enough time to do that. And then you'll have 8 minutes to do your presentation.
Okay.
All right. And I'll be your role player.
Okay.
So are you ready?
Yeah.
All right then.
Are you going to give a scenario?
Yes, I'm going to share my screen now.
Okay.
So hopefully you can see my screen now. Let me go to AAA. So can you see the screen?
Yes.
And you can see the case, right?
Yeah.
Okay, let me set the timer then. Okay, your reading time starts now. Okay, you can start the case now.
Okay. Hi. So my name is Dr. Asma. I'm your GP for today. So how may I address you?
Hi, doctor. My name is Roman.
Hi, Roman. It's nice to meet you. So Roman, I understand that you're having abdominal pain. Is that right?
Yes, doctor.
Yeah. Roman, are you in pain at the moment?
No, my pain is gone.
Okay, that's great. And so, Roman, as you're aware, that you were because we did some investigations on you, and
Yes.
so I'm going to explain the result and risk factors. And but before we begin, do you have any specific concern regarding today's consultation?
Not much. I don't know why I had this pain and now it is gone, so I'm just a bit confused.
Okay. So, Roman, because of your abdominal pain, we did an abdominal ultrasound and we found a dilatation of your abdominal aorta. That is the vessel. Let me draw it down for you. That is the vessel.
Mhm.
That is taking the blood from the body, the main vessel, to all the parts of the body. And there was an abnormal dilatation of 5.5 centimeters. Are you with me so far?
Yes.
Yeah. So the normal size is about 3 centimeters, up till 3 centimeters. So as you well aware, so this is much bigger than the normal that we normally expect. So because I just have to tell you that this could be potentially serious. I don't want to alarm you, but this is quite a big size, and it could lead to a number of potential complications. And let me first explain the risk factors to you. See, the thing is that you're a smoker and you're known hypertensive. This dilatation is due to the thinning of the vessel, which can be due to smoking, hypertension, diabetes, increased lipid. It could be familial as well. Are you with me so far?
Yes.
Yeah. So at this point, when you have a 5.5 centimeters, it has the potential to rupture, and which could be due to any cause. It could be any trauma. It could be spontaneous, which is normally it is asymptomatic, like as in your case, but it could be due to lead to it could any abdominal lead to abnormal sounds on hearing the vessel, and it could be lead to abdominal pain or as a pulsatile mass. It could rupture and it could lead to bleeding and it could lead to severe complications. And I don't want to alarm you, but like a higher mortality rate if not treated earlier. But it's good that you're here and we detected that, so we can undo that and we can treat that in time in order to prevent any complication. Are you with me so far?
Yes.
Yeah. So with when the vessel is more than 5.5 centimeters, it has a high risk of rupture, almost 75%. Even less than 5.5, it is less, but you're on the borderline. So I would recommend to treat you as soon as possible. And for that, I would refer you to the surgeon, and he would have a look at you. Are you okay with that?
Yes. Yes, doctor.
Yeah. And yeah, so they would decide that if they want to go for like the immediate, which would be the case, like a surgery, like as in an open surgery, or there are other choices as well, like microvascular surgery as well, or they put a tube inside the vessel and then they go for surgery. So that really depends on them, but this is how we proceed. Any questions you have at this point?
Do I have to go right now?
Yeah, I would like to refer you right now, although you don't have any symptom, but looking at the size, I would advise you to see the surgeon as soon as possible. And regarding the risk factors, like I know that you have smoking and hypertension in the risk factors, and I've already outlined the others. But I would advise you that at 5.5, they could ask you to go for lifestyle modification as well.
Right.
Regardless, if they do treat you for stop smoking and control your blood pressure, and I will review your medications, and we'll discuss your smoking at a separate consultation later, and check your lipid levels, and basically just keep a check on all the risk factors, and go for regular exercise, and stop straining yourself. Don't lift heavy weights, and just keep a regular follow-up. So this is what we have to do.
Okay.
Yeah. So in the event that because I've already outlined the complications, that it's better that if you go right now. Do you have any other concerns?
It's just that I have cats at home, so there is no one
Mm-hmm.
to look after them. So
Yeah.
if I go
Okay.
now,
No worries. I can just call up the social worker, and she can have a look at them. And if you want me to call anyone else in your family, I can call them on your behalf, just to let them know.
okay.
Yeah.
Okay. So then,
Yeah.
yeah, then so do you want me to go to ED now?
Yes, yes, I would highly suggest that. Yes.
Okay. So yeah, I
Yeah.
will drive to there then after
Yeah,
this
and
consultation.
yeah, if you want, I can arrange. Yeah, I'll arrange an ambulance for you. They can take you over there, and I'm just writing the referral. And but you already know that the all the risk factors, that in case there is a delay, any severe abdominal pain or any sudden decrease in blood pressure, any dizziness, that is a serious. You have to look out for that.
Yeah. I think I can drive to ED myself. I'm feeling fine. So can I just go myself?
I think it's better that it's the ambulance comes and takes you there. It's not I think it's a serious condition, and we will not take any chances with that.
Okay. So do you want me to wait here or what should I do?
Yeah, I'll just call the ambulance on your behalf. Just don't need to worry about that, and they'll take you, and they'll come with the nurse and everything. And I'll call someone from your home or your family to take care of your car. Is that okay?
Okay. Are they going to do surgery today?
Um, Not probably. I think they'll just going to discuss it with you, and the options that they put out the options for you, and I think that's for you to decide. But I think they would want you to go for that immediate surgery. Yes,
Okay. So that means I'll have to stay in the hospital.
yes, for a while. Yes, that's right.
Okay. All right, doctor. Anything else you want me to know?
Just we'll discuss the like I've outlined the risk factors, so we'll discuss the later after whatever the surgeon decides, the surgeon's consultation. We'll discuss that out there. And regarding your gallbladder, that's we can that's not an impending that danger to you as compared to this, so we can take that up later, the pain and everything, right?
Well, what is that, doctor? You just mentioned gallbladder. What was that about? I don't know about that.
Yeah, you had abnormal pain, and the it was probably suspected that that it's something to do with the gallbladder, but it turned out it's something to do with it is to do with the abdominal aorta, that, like I just said, the vessel. So that is the impending danger to you right now, and everything else will be taken care of.
Okay.
Thank you.
Do you want to stop now?
Yeah.
Okay. So first, very good. You have covered all the important points, which is good thing.
Mm-hmm.
So I think your communication skill is also good. You clearly explain everything. I have
Mm-hmm.
a few feedback. I will start with the most important one.
Mm-hmm.
If you look at this stem carefully, I'm already in ED.
Okay. Yeah. Yeah. I'm sorry.
I
Yes.
kept
Okay.
playing along because I
Yeah.
don't know
Yeah.
what
Yeah.
they will do in the exam
Yeah.
if this
Yeah.
happens.
Yeah. Yeah.
Um,
Okay.
so
Okay. Yeah.
that was the first thing because I did
Yeah,
not know
yeah,
how
I
to
should have.
respond to that.
Yeah, I looked at it and then I overlooked it. Yeah, that's right. Yeah.
Okay, so
Thank
that
Yeah,
was
thank you for pointing
one
that. Yeah,
important thing.
yeah.
But at the same time, the reason I kept playing along was because that question of how this patient goes to ED, that is a very
Mm-hmm.
important question and very
Mm-hmm.
important risk concern,
Mm-hmm.
and that they
Mm-hmm.
will try to assess in the exam. That's why I thought that maybe I will talk about that a little bit and we can
Mm-hmm.
have a discussion on that
Mm-hmm. Mm-hmm.
because
Right.
different candidates have shared different kinds of experience there.
Mm-hmm. Mm-hmm.
Um,
Right.
so as I said, your communication skill is good. You covered all the important points. You're speaking nicely. I would, if there is anything to change, I would focus on two things.
Mm-hmm.
The first thing is the organization. The information was
Mm-hmm.
good, but the
Mm-hmm.
organization was you were going back and forth. So
Mm-hmm.
I felt a bit like, I need to
Mm-hmm.
follow you through.
Mm-hmm.
Then the next thing was I felt you were under a lot of pressure.
Okay.
I don't know if you felt that way or not. And that
Just
is
the
quite
pressure to
natural.
finish on time. It's just the
Yeah.
pressure to finish on time. It's uh, you know, just
Yeah.
not get carried away and focus on the task, and that's all.
Okay. Let's just for my curiosity,
Mm-hmm.
what is your approach in a counseling case? What headings do you have
Uh,
for counseling
yeah,
cases?
I did the all the five C's, yes,
Mhm.
but I did not know about the commonality. So I take the cause, the condition, the course, like the complication that would occur, and because basically the focus was on risk factors.
Mm.
So I thought that I might have, let's focus on that first, and then go to that, because if I go in the complications and what you're going to prevent them, so that might take a bit of a time, and then I might not have time at the end to explain the risk factors. So I touch them first. That's all.
Okay. Okay,
Yeah.
good. Um, So when the question is about just explain the condition, we have to talk about everything, including the management part anyway. So you did that because someone is asking that question. Although management was not explicitly asked, it's still important to include that when the tasks is only explain condition. That is one thing. The other thing is this 5C approach. I feel like personally, because in my preparation, what I did was I broadly categorized the counseling cases into the category of conditions and category of interpretation. So basically, what I mean by that is in some cases, we just have to explain a condition, a diagnosis to the patient. In some other cases, we have to explain the investigation findings to the patient, right? And sometimes it comes as a mix of these two.
Right.
So sometimes when we try to do it in a 5C way, some of the things get missed. As you may have noticed that you forgot to talk about gallbladder and then you mentioned gallbladder at the end,
Yeah.
and I
Yeah.
pretended that I don't know anything about that, right?
Yeah.
So basically, in cases like this, but perhaps I would have started with a bit of digging of the historical background of the patient, like what had happened so far and what was done, what we have found, what that means, and then I would have gone on the line of what the condition is, and then I would have included the risk factors there. And then at the end also, you mentioned that at the end also we could have talked about two important risk factors this patient has, right? Hypertension and smoking. So one of your friends has already mentioned that um, smoking counseling and another visit. Now, another visit is a bit tricky in this situation because this patient is in ED, right? So telling a patient in ED that if you come if when you come next time, I will counsel you about smoking, just is a bit awkward, right? What you are saying is like, you'll have to come to ED again. So when it is urgent again, then I will tell you about smoking. So that I think becomes a bit awkward. So rather what you can say in this case is because most of these risk factors that we have explored here, they will be managed by a shared care, most likely through the GP as the coordinator of the care, and then specialist will be involved as needed, right? So that will be one thing. The other question I have got here is how do we respond when the patient says, I have pets at home? Now, patients can mention these kind of things like, I have children at home, I have pets at home. They can do this all the time. The reason I ask this question is in the explanation, and I will show you in the slides I have prepared that usually this part of the patient care is what we call empathy. Now, in many cases, I feel like some of us misunderstand empathy as like asking the patient I'm sorry, or telling the patient like, I'm sorry to hear this, oh that's really bad, I wish I could have done more. These kind of things, these are empathetic expressions, but this does not include the empathetic actions. So it's really important that the patient's care is when you are providing care to the patient, you can anticipate what problems patient can have and then address those issues. And one of the things in cases like this is because you are planning to admit this patient, one of the things you have to think about is the patient may have something at home. And patient in this stem, they haven't mentioned if patient has come with another person or not. So maybe the other thing is maybe this person, this patient wants to inform someone at home. Maybe he does not want to make a decision about surgery. It's a big decision for the patient, right? He came with a simple abdominal pain. The pain is gone, and now you are saying that you have to undergo surgery. It's very shocking to the patient that I came with a very simple problem, and the problem has already gone away, and then they are asking me to undergo the surgery. So these are the factors that you will have to address more on. So in this case, some key points that we have to address, in addition to what they have shown here, is like telling patient what kind of surgeries you are going to do, and telling them that they will have enough time to think about it or call someone from home, and telling them that again the decision is still theirs although there is risk, so that patient
So,
understands that patient
so
has
did
the
I cover
autonomy.
that it calls for immediate surgery, but they're going to leave it to you?
Mm.
Was that an appropriate response?
Yes, this was not a feedback to your performance. This was just a
Okay, okay,
general.
okay,
This
right,
was
right.
just a general thing that I was trying to share with everyone, so that everyone can understand what we are expected to do in this. So now I will show you what I would have done or what my approach would have been. If you have any feedback to that, or if you think that something can be changed in your method, or something can be added to what I'm saying here, you can do that. And anyone else also can interject at any time with their opinion. Okay. So basically, in conditions like this, as I said, it is important that you first address what has happened so far. Usually what we do is we straight away go to the explanation, like we start talking about what is aorta, what is abdominal aortic aneurysm, and so on. And that way, what we are doing is we are simply doing it in a way like we may have memorized this information. But what we are supposed to do in the exam is we are supposed to address the task given to us. And our task, or our patient here, has come with a different problem, but has got a different diagnosis. So that's why we should approach this case in that manner. So we can tell the patient that, okay, we might start. So you know that you had abdominal pain, you had tummy pain, and that's why we did some investigations. We did an ultrasound to see what could be the cause of your pain. And in doing that, we found that we were suspecting that it could be because of a small organ called gallbladder, but we couldn't find any problem with the gallbladder, because in gallbladder, if you look carefully, everything is normal. Now, whether you want to explain the diameter is normal or not, I don't think is that much important, because it's just normal and that's not the concern right now. Then what you have to say is, then you address the second issue. But we have found something, and that is aortic aneurysm. And then you start explaining what is aorta. So you can start by saying that aorta is this blood vessel which transports blood from your heart to different organs. Now, one thing that I want to mention here is, when I was taking classes with someone, and then I heard other people doing this role play, I heard many people saying blood tube. I felt a bit awkward saying blood tube, because I don't think blood vessel is that much difficult for people to understand. And sometimes what I feel is, because we all come from non-English speaking background, it's not our first language. I guess it's the same for every one of us. So for us, this is something like we assume that we have to simplify everything. And sometimes we end up simplifying even simple English. Blood vessel is just a simple English word. So we don't need to say blood tube. Perhaps it will confuse the patient more than make them understand. That's my understanding of this. So anyway, this is one of the probable possible explanation for this, that aorta is a blood vessel which transfers blood from your heart to different organs. When it is crossing the abdomen, it is called abdominal aorta, and its normal diameter is 1 to 3 centimeter. So sometimes it is dilated to more than 3 centimeter, and we call it abdominal aortic aneurysm. So this is a very basic explanation, and you don't need to exactly tell what aneurysm is and why aneurysm is called aneurysm and so on. You don't need to get into that. You can simply say this is what it is. Then when you are talking about the contributing factors, you can address those risk factors here. You can address them here. So the reason this happens is because the blood vessel wall becomes weak. And there are several reasons why this happens. In some of the cases, it happens just because of some problem running in the family, but it can also happen because of the lifestyle factors. And especially in your case, it looks like it is because of smoking and your high blood pressure. And then after that, you can add the rest of the risk factors. Like in other cases, it can also happen due to this. Now, how do you feel about asking patient questions in counseling stations? Do you think we should ask questions in counseling stations or not? Or should we absolutely avoid asking any questions at all?
We can ask one or two maybe.
Yeah. Basically.
Not like the history,
Oh,
like
yeah,
full
of course.
question.
Yes. Well, how I used to do was I wouldn't ask history related question, but I would ask patients, patients' concern about the things I have said. And I'll show you how I used to do that. And I think that way what happens is, when you ask patients some questions, they are bound to answer that question. Right? So when they start answering the questions, because two-way conversation always is about, you ask something, they say something, they ask something, you answer something. In real practice, that's how we do it. But for the sake of this exam, for some reason, we have made it so different that we talk a lot and we don't let our patient much chance to engage with our discussion. So basically, what we can, I will give you one example here. When we are talking about the risk factors, we can say that, so there are other factors which can also cause this. For example, alcohol or diet, or when you have sedentary lifestyle, when you have any prior history of diabetes, or when your lipid level is high, or you can say cholesterol. Many people understand this as cholesterol, or if you're quite stressed. Does any of this apply to you? So I'm not taking history. I'm just making sure that if the person has any relevant risk factors or not, in addition to what was mentioned in this time. So this way, the patient might say yes or no. And then if the patient say, yeah, I occasionally drink alcohol or something like that, then we can include that when we'll be talking about management later on. But this gives us a chance to start to break the ice and to have a conversation with the patient rather than simply telling them what they should be doing. Right. So after the risk factors, the next step we go on to is to talk about the clinical features. Now, when talking about the clinical features, again, I think the better way to say this is not by saying that, okay, when you have abdominal aortic aneurysm, you usually don't have any symptoms, and it can sometimes present with abdominal pain and pulsatile mass. This is your knowledge. And that's not what the examiner wants to see, because they have already tested your knowledge in step one. What they want to see now is how are you going to use that knowledge to benefit the patient. So rather than saying that it is usually asymptomatic, what you can say is, in many people, when they have this condition, they don't have any symptoms. And perhaps that was the case with you as well. And that's why you didn't have any symptom. And most of the times we just find it incidentally when we are doing investigations for other causes. So it can be quite surprising sometimes when we have this diagnosis, but that's what we have found in your case. And then that way, what is happening is you have mentioned that you have the knowledge that this is usually asymptomatic, and you have also customized the message for the patient. So rather than saying the clinical features, because when we are doing the counseling cases, we often say that, okay, usually this presents like this. Rather than saying it presents like this, just say that it is, in your case, you have had these symptoms, which is related to this. Some people also have these symptoms. That way you have just personalized the message for the patient, and you have also shown to the examiner that you have the knowledge of the clinical features, which is the third thing that you have to mention, right? So we have talked about the condition, you have talked about the causes, and then you have talked about the clinical features. Now, the next thing is commonality, and that is a bit difficult. Commonality is, unless you have the accurate idea of the epidemiology, perhaps you cannot say for sure how common the condition is, but you can just say that one of the tricks that many people use in the exam is it's not so uncommon. That's basically just being a bit clever about not knowing the epidemiology of the condition. And if you have no idea, I don't think it's that much important to say whether it is common or not, because once the patient has that, it doesn't matter to that person whether it is common or not, because the patient already has it, right? It is important perhaps for someone to know if in the future how likely they are to have that condition. But for someone who already has it, whether or not that condition is common, I don't think is going to make them feel any different. So the most important part of this counseling station is actually what you are going to do about it now, right? And you have correctly mentioned most of the management options here. And while offering the management options, it's very important that you personalize the message again. So rather than saying that, basically what we do is we offer the options, right? We have this option, and this option, and then the specialist will decide this for you. This is how we usually do it. While doing this, to show your empathy, what you can do is when you are giving the message, tell the patient like these are the features you have. And based on this feature, these are the possibilities. You are still saying the same thing, but you are just making it more personalized. So in this case, how we are going to do that? So because patient has already said that, can I do it later? Do I have to do this surgery? That question was actually an opportunity for you to personalize the message, talking about the complications. What you can say is the most important management point for this case, or the recommended treatment for this condition is surgical repair. And it is better if we do it before it ruptures, because without surgery, as it starts becoming bigger and bigger, the risk of rupture also becomes higher. And if it ruptures, then the person may even die. And we can do the surgery after the rupture, but again, the chances of death is very high. Compared to that, if we do the surgery before the rupture with our choice of time and method, we call that elective surgery. And elective surgery reduces the risk of rupture to less than 5% compared to the 75 to 80% chances of death when we have to do it urgently. Now the patient understands why he or she has to do it now and why it cannot be waited. Now it becomes more clear. So still the message is same that you have to do it. It's risky, it's dangerous, but now you have made it clear. If you don't do it, it will keep increasing in size. It may rupture, and it can happen at any time. And when it happens and you don't get the help, don't get the treatment immediately, you may die. Or even if you get the treatment, it's still risky, because those of you who have had the experience of managing a patient with AAA, you know how panicking the situation is. The whole hospital is on their toe, trying to control the bleeding, find the vascular surgeon to make the repair. And in some of the places like the one that I'm here right now, the regional places, it's not that easy to do it that quickly. So yeah, this is why they want it to be done electively as quickly as possible. Now, you rightly mentioned that yes, it may not happen on the same day. It may not happen on this sitting, because that decision will be made by the surgeon. The surgeon will see how urgent the situation is. And the other important thing the surgeon will have to think about in this is, if the patient is in ED, if the patient is in ED, you will be sending the patient to, if the patient is in GP, you'll be sending the patient to ED, that point we discussed. And there will be one trap for you there. The patient might say that, yeah, I'm feeling fine. Can I just go myself? And in that point, what they're trying to see is whether you have the knowledge or not that any person with the AAA of 5.5 centimeter is not allowed to drive because of the sudden risk of rupture. So that is one of the conditions, driving license condition, that any person with the AAA of size 5.5 centimeter are not allowed to have the driving license, because it can rupture at any time. So that's what basically they are trying to assess, whether you know that or not. So even if the patient says that I'm feeling fine, what you have to say is it can rupture, and because of that, it puts you at risk as well as other people at risk as well. If it happens in GP clinic, this patient is in ED, so this particular slide perhaps is not relevant for this patient, but just for the sake of the information, if it happens in GP clinic, if the patient has come back to you at GP clinic with the investigation finding, this is the point that you will have to include, even if the patient does not ask. When you are sending the patient to ED, you say yourself that now you should not be driving from this point onwards, as it puts you in risk. And if it ruptures, it will put other people at risk. So that is the other point in the management that you'll have to include. So yes, you rightly mentioned some of the options. So while mentioning the options, you presented the patient with some of the possibilities of the different kinds of surgeries available for the patient, and that was good. So basically we have two options here. Either we go for open surgery, or we go for this minimally invasive surgery with a small cut in the groin. And we don't need to explain beyond this, because it will be beyond our level to explain to the patient what actually happens. But after this, there are a few points that we can include. And these are the points that I had asked you about as well. That then after you have explained this much to the patient, you can tell them that this can be stressful. So if you want to call someone from home, it's perfectly fine. If you want me to organize that, I can do that. If you have anything to take care at home, we can organize a social worker to do it on your behalf. And if you have any other concerns, please share with me so that I can look into what we can do about that. And then after that, if the patient is, let's say again, if the setting is GP clinic, and you are telling the patient that this is what is going to happen in the hospital, then you have to, as a GP, you'll have to tell the patient that after your surgery is done and after you have been discharged, you will come back to me for your post-surgery care. And at that time, depending on whatever is mentioned in the referral letter, I will take care of you. But for this patient who is already in ED, now you have to talk about the risk factors. And what you will say is, so you have these risk factors like one of the, as I already mentioned, that your smoking and your high blood pressure are two risk factors which increase the risk of having this aneurysm as well as its rupture. So we'll have to address that. So once the surgery is done, I will organize a care review, and then that will continue with your general practitioner as well. Basically, it will involve optimizing your blood pressure as well as making sure that your smoking can be addressed. With continuous smoking even after the surgery, the risk will be there. And there is one more point that we need to include, which I think you forgot to mention. Do you know what is that point?
Not sure.
Review of the family members. Did you mention that?
No, I didn't. I mentioned it could be familiar, but no, I didn't mention it. Yeah.
So what you will do is, again, so there are two ways to do this. You can tell the patient that, yeah, I'll have to review, because it can run in the families, I'll have to review the family members. Or if you want to make it more empathetic, what you can say is, as I have already told you that usually people with this condition may not have symptoms, and it runs in family as well. There might be some of your family members who may already have this condition. So if we do the investigation for them now and find out, then we can provide the same level of care to them as well, and it will reduce the stress and will reduce the risk as well. So basically what I'm saying is, rather than generally presenting the information that the risk factors are familial, and sometimes it runs in the family, so we'll have to screen the family members, you just personalize the message for the patient as if you are talking to that patient, and rather than giving them the information, have a conversation with them. That's how I think we should do this, because this was my exam case and AAA. And yes, I did not talk about anything advanced. I did not talk about anything hi-fi. I just talked about the simple things like, do you have anyone at home to take care of your things? Do you want me to call someone from home? How are you feeling right now? It can be quite distressing. Do you want me to organize anything for you? And then I said the same thing, like this thing can be asymptomatic. This thing can be there without causing any problem. So if you have a family member who has this, because it tends to run in the families, they may not know about it. So it's important that you let your family members know about this, and they also do their investigation to find out if they have the condition. So that's how I did this. And this is obviously this was the counseling case, and I have got good score in this one. This one is the one where I scored 6, I think. So, and then the only thing I felt I did differently was I was more engaged with the patient, and I was asking questions as well. Like, how do you feel about that? Do you think we can do this? Do you have any problem with that? Do you have any concerns? So I kept doing this. The other thing is you kept asking me whether I was following you or not, which is very good. And so after doing that, if there is any point the patient has mentioned, or any point that you have mentioned to the patient, you can ask like, do you know what it is? Have you heard about this before? Do you know how it is done? You can do that as well. Because sometimes if you're just saying, are you following me? Are you following me? It sounds like this is just a routine question you are asking, right? Again, this is not a criticism, but I think this is just an additional point. Take a cue from patient's answer and use that to ask another question.
Right.
So I have a question in chat here. I've seen one case where aneurysm size is 3.9. So how often we should check the size, yearly or 2 yearly? Okay, this is a very good question. And I have done a lot of research about this. And then the answer is there is no specific guidelines about the frequency. If you look at the RSCCP guidelines right now, they have a different screening guideline there. And then this Australia, New Zealand guideline, that one says different. If you look at the European Vascular Society guideline, that is different. So basically what I had decided, although I didn't have to do this in the exam because my case was 5.5 centimeter, but if you get this in the exam, what you can simply say is, so you will have to be reviewed by the surgeon or by doing the investigation, and the frequency of this review will be determined by your surgeon depending on the size of your aneurysm. That way you have said that, yeah, if it is bigger, you will have to be reviewed more frequently. Because I think memorizing the number is not as important as letting the patient know that if their size is bigger, they have to go for a review more frequently. Most of the times for patients, these numbers do not mean much. What they want to know is, when do I have to come again, right? And because this decision is not made by a GP or by a medical officer, this is made by the surgeon. That's why you can say the same thing. This decision is made by the surgeon, but usually if the size is bigger, you do it more frequently. And if we find that it is increasing too rapidly, or in case of female, if it is more than 5, in case of male, if it is more than 5.5, we determine, we find out the right time to do the surgery. Before the surgery, we'll do your review to see if you are fit for the surgery or not. And if there are any issues, we'll address those issues. That's basically what you can tell to the patient. All right. Do we have any questions about this case? Or does anyone have any other interesting ideas to share? Please, you can unmute yourself and we can have a little chat. It will help everyone. Okay. So looks like no one has any confusion about this one. We can move on to the next one. So who is ready to do the next one?
I can do. It's the Colles fracture.
Yeah, okay. So I just had a question here. Should we discuss about the surgical complications at this stage? Because we haven't reached that stage, I don't think it will be relevant. But if you have time, then rather than staying silent, you can talk about the surgical complications. Because I think this is one thing the patient would want to know, how risky the surgery is. The only thing we have told the patient is it reduces the risk to less than 5%. But then can the surgery itself have some complications that perhaps will be relevant? So if you have time, you can talk about that. The surgery is generally safe when it is done electively, but still there can be risk of bleeding, risk of infection or injury to the surrounding structures. So you can just give a general idea. Any other specific complications will be communicated to you. Okay, 3.9 centimeter size and patient wants to go to trip. What should we say? In this case, you will tell the patient that they will have to be reviewed by the vascular surgeon first. And depending on their advice, it will be a good idea to go on the trip because they will determine if there are any other risk factors that can increase the risk of rupture. That's why in this case, that you will notice that in the exam, we have different diameters. One is 7.5 centimeter, one is 5.5 centimeter, one is 3.9 or 3.5 centimeter. The reason we have these different diameters is they want us to show our understanding of that. For a patient who has a diameter of more than 5.5 centimeter, 5.5 or more than 5.5, we have to urgently refer to them to the surgeon for the surgery. But for the others, what we tell them is that we are going to make an urgent referral, but that is for the review. That is urgent review rather than urgent surgery. So urgent review will be done by the specialist depending on their availability. And until that review happens, we have to tell the patient what kind of lifestyle modification they have to do. And in this case, 3.9 centimeter case, again, the patient is smoking. So you have to tell the patient that until that time, it's important that you try to avoid any kind of trauma or be involved in any kind of contact sports. Make sure that you are not lifting heavy objects or not doing anything where you have to do strenuous activities. And then you have to stop smoking, because if you continue smoking, then the wall becomes weaker and weaker, and then the risk of rupture also increases. It's also important that your blood pressure medications are optimized and so on. So it goes in that line. So that one is more about the preventative activities until the surgery is done, or to let the patient know that they have to be in a review program. The one which is 5.5 centimeter onwards is to check if you have awareness about the surgeries, what kind of surgery is done. And the other thing is, any case with the surgery, they want you to know that whenever you are keeping a patient in the hospital urgently, especially a patient who came for a minor complication, but now has been told that they have something else going on as well, you have to also tell them that they can call other people, they have all the support. They just don't, it's not that they have to do it anyhow, because still, although this is emergency, they are still competent to make decisions. So still it's their decision what they want to do. So you have to let the patient know any kind of urgent care, they still have, as long as they are competent, they have their autonomy and they can make the decision themselves, regardless of what the implications can be. But we have to let them that if they don't want to do that, as in this case, if the patient is like, no, I don't want to do surgery, we have to let them that it's still your decision and we respect that. But I want you to understand that this is what is going to happen if you don't do the surgery. So do you understand that? And if you want to really make sure, and if you have time, you can ask, so can you please tell me what you have understood from this? Because that's how it is usually done. If the patient refuses the care, then we usually ask the patient to repeat what they have understood so that we can establish competence. And later on, if there is any issues, we can say that patient had done this and this was an informed decision. I guess that answers the question. If not, please let me know. Otherwise, if anyone else has anything to add, especially if there are any specialists in this group right now, if you have any other interesting things that you know or anything that we may have misunderstood, please feel free to share, because that's what we are doing here. We are trying to learn from each other. So if anyone knows anything better, please share. If not, if we are all right, then we can go to this case of Colles fracture. So you ready for Colles fracture now? Okay, so you may need to unmute yourself first.
I have unmuted.
Okay, that's good. So you're ready, right?
Yes.
Okay, let me find the case for you. And this one is actually, perhaps you will finish it earlier than the given time. And in this one, we'll also discuss what to do if that happens in the actual exam, how you can, spend the rest of the time.
So
In
do
the
you want
exam,
me to do
yes.
the video consultation or audio consultation?
Sorry, I missed that. What was that?
Video consultation or audio one? Like I should put my video on?
Yeah, that's better, because then I will not feel like I'm just talking to these names.
And for me as well too, because of counseling.
Yeah. Okay, so this is the case. So as we did in the previous case, you will have 1 minute first to think about the case. As you know that in the exam, you have 2 minutes. You're just doing it 1 minute here. And then you will have another 8 minutes to do the counseling. If you finish earlier than that, it's fine, because in this case, most likely you'll finish earlier than the given time. If that happens, we'll talk about what to do in the actual exam when that happens.
Okay.
All right. So your 1 minute timer starts now. Okay, you can start now.
Hello, I'm Dr. Zanera, one of the doctor here. Nice to meet you. How can I address you? If you can remind me your name again.
Hello, doctor. My name is Roman.
Nice to meet you, Roman. So, Roman, I understand from the notes that you had a Colles fracture. Is that right?
Yes, doctor. I had fracture.
Okay. So, how are you doing at the moment? Are you in any sort of pain at the moment?
No, I was given some medicine, so I'm all right now.
That's good to know, Roman. So, Roman, we have taken care of your fracture, and the good thing is that we have not found any vessel injury, any nerve injury, any muscle injury. Okay, and we have applied the cast. All right. So let me assure you that we have taken good care of your fracture, and now we are about to discharge you. Okay. And I'm going to explain you what exactly you are going to do now when you're going to go home. I'll try to make it very simple for you, but at any point you don't understand anything, feel free to ask me, okay? I'll try to make it more simple, all right?
Okay.
So let me first tell you what exactly happened, Roman. So basically, what you have is a fracture, which we call in medical term as Colles fracture, okay? It normally occurs when we fall on an outstretched hand. Basically, let me draw a diagram to make it more understandable. So we have a one thick bone and one thin bone in our arm, okay? So basically, when you fall on an outstretched hand, it causes the upward tilting of the bone. But I can see from the note that you hit your hand on the door. So the mechanism remains the same, Roman, because it causes when the upward tilting of your hand, it can cause the fracture of one of the thick bone, all right?
Okay.
But the good thing is that it's just a minimal displacement. So nothing to worry at the moment. So we are going to discharge you and we are going to give you painkillers, okay? So after going home, you have to take the painkillers as prescribed, all right?
Okay.
And what you can do to make this more comfortable, you can apply the ice, and you can just put a thin sheet of cloth in between the ice and that cast that is applied, and you can apply it like every 2 hourly, okay? It will give you a comfortable feeling, okay, especially for the first 2 days, all right?
Okay.
And most important is the follow-up care. So what you have to do, that try to put your arm on the pillow proper position, okay? It will reduce the swelling, all right?
Okay.
And try to put it above the level of heart, okay? It will also help you, comfort you, and to reduce the swelling, all right?
Okay.
And try to move your fingers, Roman. It's like don't completely not use that hand. Just try to move your fingers here and there so that they don't get stiff. Okay.
Okay.
But don't carry any heavy objects with your hand, or don't do any strenuous exercise at the moment. All right.
Okay.
So we are going to teach you exercise as well. We are going to refer you to physiotherapist as well, who is going to teach you what exact exercise you have to do that will help you in the recovery. Okay. As I said, that follow-up care is very important. So you will be referred to the fracture clinic. You have to visit to that clinic. Basically, in 2 weeks' time, you have to visit, and they will see that if that cast have not loosened up or not. Okay, they will assess the situation more better. All right. And normally these type of fractures, they recover without any complication. Okay. And you can, we are going to remove the cast in about 5 to 6 weeks time. All right. And then most of the time they recover in 3 to 4 months. Okay. But it's important that you don't, during that time when you have that cast, try that it should not become wet. Okay. If you have to take the shower, you can put a plastic bag over it. Okay. If it becomes wet in any way, you can use a dryer, because it will take time to dry itself. All right.
Okay.
Are you with me so far?
Yes.
Do you have any concerns so far?
No.
Okay. So most of the time, as I have said, that they heal and recover without any complication. Okay. But sometimes it happens that the pain is not getting better, or you're still having the strain sensation, or there's still the stiffness despite of getting discharged. So at that point, specialist might decide to do an MRI to see what exactly happening. All right. Otherwise, follow-up X-rays is normally not done. Okay.
Okay.
And sometimes it can happen that even throughout your life, with some patient, not for all, but sometimes, because I am here to make you aware that sometimes it can happen that you may have some difficulty with range of movements here and there, and some pain on and off. But as I've said, it can happen in lesser proportion of people. Okay.
Okay.
Okay. And one thing, Roman, is that like considering your age, you are 60 years of age, and also you have this fracture. So one of the factor that we consider is osteoporosis, which is a thinning of the bone. Okay. So after your follow-up and its recovery, we are going to basically assess you for the osteoporosis. I'm going to refer you to the GP so that he can do the investigation, and he can in detail guide you what exactly you have to do, if you have any factor, how to counter it, what diet you have to take. All right. Are you with me so far?
Yes.
Okay. And after removal of the cast, initially your hands or fingers might feel stiff, but they will get better eventually. Okay.
Okay.
But it's very important that after getting discharged, you go home, and if you feel your pain is not improving, it's increasing, if any new pain that you're feeling, any weakness, any tingling, any numbness, any redness, Roman, it's very important you come back to ED or your GP. Okay. Okay. And do you have any concerns so far?
No, doctor. Is there anything else I should know?
For now, these are the things that are in my mind, Roman. I think I have explained whatever in my mind, but if anything comes up, I will definitely let you know, and I'm going to give you reading material regarding it, so that you can have a read as well. Okay. And I'm going to arrange a review with the fracture clinic, with the follow-up clinic, and the GP as well. And I will be giving you all the referrals on the discharge. Okay.
Okay.
And if you have any question until the discharge, I am here. You can call me anytime. Okay.
Okay.
Thank you.
Thank you. So yeah, we finished 1 minute earlier than 8 minutes. It's fine. I think in the exam it will be 8 minutes, because in the exam things do not happen this smoothly usually. And the role players have their own instructions. So yeah. So good thing is you were quite relaxed and your speed was quite good. And I think it's easier for the patient to understand when you go in this way. And then you started by talking about what happened to me first, then simply talking to me about what I was going to do, which I think is a good way to build the rapport and then connect with the case as well. So that was a good point. most of the important points you covered. You told me about the care of the cast. You told me about what to do in the follow-up. You told me about the fracture clinic. Did you tell me about the red flags?
Yes.
So which red flags you mentioned?
If the pain increases, any new pain comes, if there's any tingling, numbness, any straight sensation, or any stiffness in the finger, just go to the ED. Or I said go to the GP, but I think go to the ED.
Good, because that was one thing I may have missed. But otherwise, I think you said all the important things. Just minor feedback. The things that I would include, because it's a counseling case, you are discharging the patient. It would be perhaps relevant to ask patient like, do you have support at home? Do you think you'll be able to do your activities by yourself? Is there anyone who can take care of you? And do you need to go back to work, or do you have any work commitments? And do you want any certificate for that? And the other thing is 60, but still, I think you should ask, because 60 is still not the age for retirement for people. When you were mentioning the dryer, I think it would be important to mention that when you are using the dryer, blow cool air or cold air, not the hot air, because dryer usually the default setting is hot air, and we don't use hot air to blow dry. The points you mentioned were quite good. And regarding the minimal trauma fracture, I think we can ask one question there. So you mentioned, I could see in the note that you hit your hand on the door handle and you had the fracture. So did you really hit it hard, or how did that happen? Because it looks like it was just a minimal trauma fracture, right? But just asking a simple question about the mechanism of fracture perhaps will make it even more clear. And that will also give you a chance to explain about the minimal trauma fracture. And you can say that, so as you can see that this kind of injury is not strong enough to cause the fracture, but in your case, it has happened, means maybe the bone is not as strong as it should be. And in this age, our concern is, the first concern is the thinning of the bone, which called osteoporosis. And then we are also thinking about the other possibilities, which need to be addressed quickly if they are there. So basically, we are talking about malignancy when we are saying that. So that is the review part. Basically, you have said the same thing. I'm just trying to connect it to the patient so that it becomes more, patient specific. Because in counseling cases, I have heard this story that in counseling cases, many people fail, and despite doing all the right things. And I as I told you in my previous sessions as well, I didn't have any study partners to say how people usually do it. But the only thing I've seen is people doing the role plays in the classes I was taking. I never did role plays in those classes, but I saw people doing things. And then I had my own reservations about this style, like talking about all the important things, but as if you are reading from a paper rather than having a conversation with the patient. So having a conversation always means that you have to ask something to the patient. And in addition to asking, are you with me so far? Is there anything you want me to explain? You should be asking something specific to the patient. As in this example, when you are saying that you're discharging the patient home, do you have anyone to take care of you at home? Do you think you'll be able to manage your daily activities? That's a very specific question to the patient, because it shows empathy that you are concerned about how the patient's one hand is fractured. So you want to know what he's going to do about that. That's one thing. And it will help you to increase your score. I don't think it's a failing point, but I think it will help you to increase the score. The other thing is when you are talking about the fracture clinic part, perhaps it will be a good idea to give patients some materials about the fracture clinic, about how they are going to. I'll give you some reading materials about the fracture clinic and how you are going to approach them, so that it is easier for you. And the other things you mentioned quite clearly and nicely. So I felt like most of the important points were covered. Now, this is my explanation. Again, feel free to interject at any time and give your input. Or if you feel like something could have been done in a better way, please let me know. So basically, as you started, I would also start by first addressing what has happened so far. And then after that, I would start talking about the condition, like what is Colles fracture? So you mentioned Colles fracture. I think in all of these counseling cases, when you're talking about conditions, make sure that you have your lines ready for the exam, because in the exam, if you have not done it before, it will not come out that easily. I don't know if it happens to native speakers or not. And I don't know if this is the issue of being non-native speaker, but in the exam, sometimes even the simple things become very hard to explain and you get stuck trying to find out the right word or right sentence. So for all these conditions, try to have those small lines, those small, phrases which you can use in the exam. So you don't need to memorize the whole sentence, like fracture of the bone with the upward tilt. So basically, this will help me to remember that there is a bit of upward tilt, and then there is a fracture. So both of these points are there, and that way I will not forget. Now, how I make the sentence, it's up to me, right? But at least this point should be there in my explanation of the condition. And then after that, the other thing which is specific to this patient is this can happen due to trauma, as you mentioned, that it happens when you have fallen out to stretch hand, but sometimes it can happen with minimal trauma, which might be the case in your situation. And this is usually when the bone is weak. In your case, it looks like you have had the fracture due to minimal trauma, and I will consider this in your management. I can talk about this here, but I think this will disturb the flow. That's why I'm saying that I'll consider this in your management so that I can finish talking about other points. And when I reach that point, I can talk about this. Or let's say for some reason I run out of time, then still I have addressed this important point. Not completely. So let's say that if my score is 4.443, there is a good chance that I might even pass. So then after that, you have to explain what you have done. For now, we have applied the cast, and the cast will be there for 6 weeks. This is another important point, time. Usually patients will ask, when can I take it out? Because for them, the concern is because this one of their hands, they will not be able to use. So of course, they want to know when they can use it again in a normal way as before. The next important thing is the review after 24 hours. This review is done to find out if there has been any swelling causing compartment syndrome. And that's why you will do another review after 24 hours to see if the tightness of the cast has caused any problem of the blood flow to the distal organs. And then then you have to say that if that has happened, or if we find that your blood supply has been compromised, we'll have to take out the cast and reapply it. Assess and reapply, right? And then the other thing, the patient is going home. What other things they will need? Right now, the patient has said that the patient has no pain, but the pain will come back because right now they are under the influence of the anesthesia, and maybe they have already been given painkillers. But when they will reach home, then they will have pain. So you will have to tell them that you will give them painkillers, which they can take as needed. In the initial 3 days, it's a good idea to take them regularly, and then after 3 days, they can take as needed because the swelling and the pain will subside after that. But if they feel like the pain is not getting better, or if they feel like they are numbness and tingling, or if they feel like they have any fever, or there is high temperature, there is localized high temperature or fever, then in that case, they will have to come back, which you will be explaining during the explanation of the red flags. Basically, in this counseling part, what I have done is first talk about do's and then talk about don'ts, what they should do and what they should not do. What they should do: if they feel any pain, they can take the painkillers, and you will prescribe them some painkillers. And you can tell them that there can be some mild swelling, so you have to elevate your hand above your heart level. And you can use a pillow while sleeping so that the swelling gets less. And if you feel that the swelling is getting more, you can also use ice. And as you rightly mentioned, wrapped in a small, thin paper, thin cloth, so that you do not directly apply the ice over the skin. And the other thing they should do is they should regularly move their move their fingers, so that they can, the blood flow continues and there will not be stiffness. So you will say that you will have to do this, otherwise this will happen. And then you will do this so that this happens. So you talk about either the purpose of doing that, or talk about what may happen if someone doesn't do that, so that they understand clearly what could be the risk and what they will be missing, or what problem they will be bringing in by not doing that. So in the do's part, and then you go to the don't part. So what they should not be doing. What they should not be doing is they should not be making it wait. But they will have to take shower. So you can tell them that you should not make it wait. So if you have to go to shower, you can wrap it in a plastic bag and then take a shower. If by any chance it gets wet, then you can blow it dry. But make sure that you use the cold air rather than the hot air from the dryer. And the other thing is, do not use any lotion or powder near the cast, or do not use, because it becomes quite itchy. So some of them just insert a stick or something inside the cast and then start scratching. So you have to tell them that it can become itchy. If that happens, don't use these sharp objects or any stick to put inside the cast and scratch, because if it injures the skin there, then it can get infected, and then that can cause more problem. So what else they can do if they have any scratches, any itchiness? What will be the option then? You are saying that it will be itchy, but don't scratch. That is not a solution, right? So what is the solution then? Anyone? Yeah, you can use a hair dryer and cool. That will soothe the skin a little bit, and then your itchiness will be less. Antihistamines, yes, you can try if it gets really bad, but I don't think it will be that bad. But if it happens, then they can try antihistamines as well. So these are the two possible options you can try if the patient, because this is a real problem that people will have, and they can use some this moisturizing lotions. They cannot insert it inside, but the hand also can become dry because you'll mostly be, putting it upwards, and you'll not be using it as much as you will be normally using it. So it can feel a bit stiff. So you can use some moisturizing lotions. You can move the hands. And by the way, there has been a slight change in the fracture management cases these days. In most of the fracture management, conservative management, we have been using this RICE protocol. But this RICE protocol has become a bit older, and then there are newer protocols that people have started using. Does anyone know what is that new protocol? I'm not talking about Colles fracture right now. I'm talking about fracture in general. So fracture or sprain, we use this RICE, right? Rest, ice, compression, elevation. If anyone knows, you can share. Otherwise, I'll tell you anyway. So the newer protocol that we are using, or which is getting more popular these days, based on the recent evidence, is POLICE. POLICE is P is for protection. So earlier we used to say rest. Nowadays, what we are saying is for the initial 24 to 48 hours, when there is acute injury, you may not be able to use it, and perhaps using it will cause the problem even worse. So for the initial 24 to 48 hours, you can rest. But after that, protect and police. P is for protect. OL is for optimal loading. Protect and use it. Use as much as you can tolerate so that there will not be any stiffness of the joint. So that is POL. And then rest of the ice is same. Then you use, and then again, ice, compression, elevation, that's the same. So only difference is, unlike RICE protocol, where we ask the patient to rest the joint, what we are saying now is protect, and then after that, optimal loading. Protect in the first 28 to 40, 24 to 48 hours, and then after that, there should be optimal loading. You should use it as much as you can. You may not be able to use it as much as your normal hand or your normal limb, whichever has been fractured, but you should try to use it so that there will not be stiffness. Because what evidence or what studies have found is, like, if any joint is not used for longer than 48 hours, then the chances of stiffness increases. Immobilization for more than 48 hours increases the risk of stiffness. And that's why now they're saying that more than 48 hours, you should start using it as much as you can tolerate. Now, so far what we have done is we have mentioned to the patient what the condition is. We have mentioned to the patient how it normally happens, and in this patient's case, how it has happened and what we are concerned about. And then after that, we told them that when the cast is going to be taken out, and we told them do's, what they should do, and we told them what they should not do. The next step is to tell them when they need to get immediate medical attention, and that is what we call red flags. So in red flags, in most of the fracture cases, I use this mnemonics, Vinco, where V for vessels, I is infection, N is nerve, and CO is compartment syndrome. So you have to mention at least these four things. Talk about the vessels, talk about the infection, talk about the nerves, talk about the compartment syndrome features. So vessels, you'll say that if you find that your limb or your fingers are turning blue or pale, then you have to come back immediately. If you get any fevers, if you start seeing any blisters, if you start getting this offensive smell, then in that case also it indicates infection. You have to immediately come back. If there is any kind of tingling, you cannot move your finger. If you feel any kind of numbness, you have to come back. And if your pain is not responding to the painkillers, if on minimal movement also you are getting a very severe pain, that also indicates that there can be the compression of the structures underlying. So you have to come back. So basically, I said do this and come back. If this is the case, come back. That's not how you will say it, obviously. What you will say is, if you have this, if you have this, if you have this, and if you have this, then that is an indication. That is an indication that you need immediate medical care. That's why you should immediately come back to the emergency department so that we can review it and provide you the appropriate care. So that's how you will talk about the red flags. Then after that, the other points, as you mentioned, review points. So review, as I already said, the first review will happen in 24 hours. And the next review will happen in the fracture clinic, usually in 1 or 2 weeks. I'll organize a referral letter to fracture clinic, and I'll also inform the fracture clinic about your case so that they know that you will be coming there, or they might contact you. And then after that, after the 6 weeks, your cast will be taken out, and then you can be enrolled in a physiotherapy program for active exercise. Then, as I mentioned earlier, if you have any problem doing your everyday activities, we can do occupational therapy assessment, because the patient is around 60, which is now almost the age where you are more likely to need this kind of help. And then if you need to go back to your work, I can organize work assessment and rehabilitation program as well. So basically, in all of the counseling cases, especially when you're talking about conditions, whether they are acute conditions or chronic conditions, in the management part, it will be a good idea to think about what will be the immediate care. And in the immediate care, you will think about pharmacological or non-pharmacological care, lifestyle changes, and then you will go about the long-term care. Long-term care, again, you mostly will be about lifestyle changes and any ongoing medications. I'm talking in general, not about just this case. And then at the end, always remember ancillary services. Ancillary services usually means maybe counseling, maybe support groups, maybe these uh, rehabilitation programs, maybe physiotherapy, depending on what the case is. So basically, if your management is structured like this, you are less likely to forget the important points. So you will talk about what we are going to do now. You will say what we will be doing, what will be the ongoing care, and then ancillary services. Because in Australia, and especially in this AMC exam, they are very much particular about providing patient with the appropriate support, because their support system is quite good compared to other OECD countries. Australia has a very good health system, and their support system is quite good. And so maybe that is the reason they want us to take advantage of that. And so for some of us who come from a different background, this support system perhaps did not exist, or we did not use them as much as we use, or we have to use them here. And that's why in every case, try to think what is the support system available for this patient and try to include that. So just this one point, ancillary service. What ancillary service can be useful for this patient? And then include that information. Then the most important point here in this case is, this is a case of minimal trauma fracture, as we have been mentioned in this term as well. I think that was the intention of saying that the patient hit his hand on the door handle and then had the fracture, because that's not usually how this fracture happens. So you have to indicate to the patient that this could be the case, because you don't know for sure right now. You'll have to do some investigation. So you'll tell the patient that this could be the case, and then I'll have to arrange a referral. So in this case, we'll do the referral to a special service that we call fracture liaison service. This is especially available in New South Wales. I'm not sure about the other states. Maybe you can check yourself and find out if in other states also they have this kind of program. So basically what they do is they will provide the after fracture care, and they will do the necessary investigation for the patient. So, and then you can say that after that is done, the further management will depend on what we get from the investigation. But as more information becomes available, you will be explained about it. If you are GP talking about this, you will say that I will explain this to you. If you are in ED, then you will say that this will be explained to you without mentioning who is going to do that. So this is how you can do the counseling case of Colles fracture. I think we have covered all the important points. And if you do this much, I think there should not be any problem in this case. But if anyone else has any ideas, please feel free to share. Or if there are any questions, let's discuss that first before moving on to the next case of migraine.
Hi.
Hello.
I have a question. I did my exam before, so this was one of my cases, and I failed that case. So I think I missed the point of who will take care of you at home. I didn't say this type of things. Just I finished with the fracture clinic and all, and reading materials. So maybe that was another thing. And the patient was continuously asking me what type of painkiller you want to offer me. So I said okay, I will go for NSAIDs. And I start to explain, and he said, you want to give me NSAIDs? You want to give me that? Then I got a bit feared up, and I said, no, I will go for paracetamol. like, you know, like I feel very down. I started
they do that. They do
yeah,
that,
so
and I know because this happened to me as well. Although fortunately I passed that case. It happened to me mental state examination where the patient was like, patient said, oh, and then she made a face. And I felt like, did I say something wrong? I couldn't even remember what I said, but I felt really scared because because the way the patient's expression changed, I felt like I must have done something wrong. Why the patient is suddenly making that face? I don't know why the patient did that. I don't know what I did wrong, but they usually do that. And if that is an indication, that does not mean that patient, this is one thing that I have learned, um, not just through my experience, but by listening to other people's experience as well. And based on my reflection on what should be done in that situation, patients have been instructed to give you particular expressions. These are not real expression, right? We all know they have been told, do this if this happens. And why is that done? This is to see how you will respond to that situation, because we are supposed to respond to anger, we are supposed to respond to disappointment, we are supposed to respond to sometimes abusive patients, but we know that these are all role players doing their part as they have been told. And what they're trying to say is, how do we respond to that? I'll give you one example. This is again based on how I have understood this. There is a case of this irritable bowel syndrome where you explain to the patient what this brain gut axis is, and then patients make the face saying that they are not happy with what you are saying. Now, in that case, is it because we are saying the wrong thing the patient is not happy? No. The reason the patient is not happy is patients of IBS usually, when they are told that they don't have any particular organic basis of their symptoms, they have been told to give that expression. It's not because of your answer, it's actually what they have been instructed to do. Right? Because that's what usually happens when you tell a patient that their symptoms are actually because of an underlying mental health issues, because it's a very stigmatized part of medicine, where whenever you tell patients that it's all in your head, because basically that's how they take it. Although you know that there is a basis, they usually take, okay, you are trying to say that it's all in my head. And that's why they are responding in that way. So you might have been doing the right thing. The expression is just the set expression for that particular answer. That is one thing. The other thing is, you mentioned that once you mentioned NSAID, then the patient was like, you are going to give me NSAID. If that happens, you can ask patient why they are so concerned about NSAID,
All right.
isn't it?
So should we start with NSAID or should we start with paracetamol? Then if it doesn't help, then we'll go for NSAIDs then.
Usually, I'll tell you how it is done in the real practice. Usually what they do is they give this codeine containing drugs, and then they say there's if the Panadol Fort, like, use this if the pain is too uncontrollable. Otherwise, you can just take this paracetamol 3 times a day for 3 days. And then later on, you can take it as needed. If the pain is too much, then you can use this. But one of the trap here in this case is, I'm talking about pain in general. One of the trap in this case is because you have mentioned to the patient that if the pain is too severe, you have to come back. It could be compartment syndrome, right?
Yeah.
So if you are just saying, if you tell this patient that, just like in other pain management case, if your pain is not controlled by simple analgesics, you can also take this. In case you need this, I'll give you this. Because in many post-surgical case, that's what they do. They give you this opioid containing drugs and the limited prescription of opioid containing drugs, but they tell you that until you need it, you should not use it. As much as possible, use this paracetamol and NSAIDs. And if it is not controlled by this, then you can use opioid containing drugs. But in this case, I think it will not be a good idea, because one of the indication for the patient to come back is pain, which is not responding to painkillers.
Yeah.
Right. That's one thing.
Yeah.
But yeah, please feel free to share, because it helps everyone when you share this experience.
Yeah.
Do you remember
Thank you.
anything else?
The first it was okay. Like I just whatever you like you're like whatever you taught here today, like I just went through like that way, like all the red flags and what if the each thing is easy and everything I did, like up to fracture clinic and everything I like said. Then when the patient asked about like the painkiller, when I said like I will give you some painkillers, and so the patient was, oh, what type of painkiller you want to offer me? Then first I think, okay, maybe anti-inflammatory, okay, I will go for NSAIDs. Then patient, oh, you want to give me NSAIDs? Then I got feared up and I said, no, I will give you paracetamol first. Then I will, if the pain doesn't like decrease, you can take some NSAIDs as well. Then I think the patient didn't like it. Then at the end, when I finished everything, the patient was kept asking, "What else you wanna say me? What else you wanna do?" And I was like bit confused. What I have missed? Like, what should I say now? Like, uh, I think I missed that. Like, yeah, well, like when he will be at home, like what should, like, if there is any help for him there or not. Like, I should have asked that. So, and I was also
Hmm.
thinking about, like, as he was having a minimal trauma fracture, like, and he came with a fall and he had the fracture. So I should have asked more about the, like, fall thing, like, do you have any vision problem or any, it's my opinion. I should have asked, like, do you have any vision problem, any dizziness that you have the fall, or any, like,
Yes, good
about
point.
the, yeah, furnitures or anything. Like, the we always ask about the fall things. So I
Yeah.
should have asked those questions, like
Yes,
as the
yes.
patient was so adamant about it.
Yes, I think that's a good point because the patient had a fall and then had a fracture, and this patient is 60 years. So I think it would have been a good idea to ask, like, um, how did you have that fall, or did you trip on something, or, I mean, how so mechanism of fracture always gives us this clue about how this happened, and that was the reason why I told you in this counseling as well that it will be a good idea to ask that question. So counseling cases, usually our state of mind in the exam is it's a counseling station, means I need to tell the patient, but optimal patient care is always about adherence and concordance. The things have changed. There was a time when we used to talk about compliance. Compliance is more about you tell patient something to do and patient do that. But here in the modern patient care, it's all patient centered, right? So rather than telling the patient to do something, we actually want to find out something that patient can adhere to. Or even better, which is more theoretical, is concordance, which means that you tell patient something, you ask the patient if that is appropriate for them or not, you negotiate, and then you come to a point where you find a solution that is acceptable for you and the patient both, right? That is what concordance is. Practically, that's very difficult thing, and perhaps we'll not have time to do that. But basically what it tells us is, in exam situations, which is an ideal situation, in exam, the reason we do many things that we don't do in practical situation is because exam is an idealized environment, right? And so in that environment, we are supposed to do the things that we should ideally do. And that is the reason why asking these questions, like, how are you going to manage your daily activities? Is there anyone at home who can take care of you? When the pain is, you have said that when the pain is out of proportion, what does that mean? What is out of proportion pain? Is it the pain that is not controlled by simple NSAIDs, or is it a pain which is not controlled even after taking the opioid analgesics? So if you go to that analgesic ladder, you can go up and up, right? So how far patient should go with the analgesics before deciding that no, it's not working, and come back to the healthcare? So these are the things. And for our level, or the level they want us to be in the exam, I think it is safer for us to say that if you are taking the painkillers, and then I think the maximum we can go is up to NSAID, and if it's not working, you can come back. And in your case, because the patient kept saying that NSAIDs, do you want me to give NSAIDs? Two questions that could have been relevant is, do you have any allergy to NSAIDs, or do you have any kind of this um, uh, tummy pain or belching or heartburn, this kind of symptoms, so that you can see if the patient has any issue taking NSAIDs. Because if the patient, you said NSAID is not a common term, right? If the patient is able to repeat the word NSAID and say, do you want me to give me NSAID, means they know about NSAID.
Yeah.
And usually patients might say aspirin, but why, if they are saying NSAIDs, that means they know about this somehow. So you can ask, like, is there any concerns? Have you used these medications before? Has anything happened? These kind of clues are always given in the exam. And I had this incident in dysthymia case, the so-called dysthymia case of psychiatry, where I kept asking patient many, many, many questions, and I was not getting any positive finding. And patient kept repeating that if I sleep during the day, then everything becomes better. If I keep sleeping in the day, then everything becomes better. And I was trying to figure out, what does that mean? Because it doesn't mean narcolepsy, because narcolepsy is like you fall asleep. It's not that you decide to sleep. So I was trying to get that idea. What clues she is giving me? What is she trying to tell me? She's trying to tell me something by repeating that line. She must have been instructed to do that. So, but what is that? So, so What I'm trying to say is, if in the exam you find that the role player is insisting on some points, repeating that points, that means it's not that they want to do that. It's that they have been instructed to do that, because that's a clue that your examiner thinks will help you to solve that case. So you now have to come up with a solution to that. I remember the other thing is, what was that case? It was a gynae ops case. Yeah, the case of this pregnant lady taking marijuana. In that case, I felt like she was sad. I felt like she was sad, and that's why I asked. Because every patient, any one of you who has been in the exam, you know that every patient will have different expressions. Some of them will look quite happy, some of them will be like flat expressions, some of them will be looking quite sad. The reason they have those expressions is because they have been told. Now, of course, in the online exam, when you have to sit in front of the computer for 7-8 hours, maybe that makes them tired, and by the end of the exam, maybe that expression also changes. I don't know. But different patients will sit there with different expressions. Some will be cheerful, some will be sad. So in that case, I asked her, is there anything concerning you? You look quite worried. Is there anything concerning you? And then she asked me, like, is this going to affect the baby? So that was a simple question. Maybe that question was there. They wanted me to ask that question. Maybe that clue was there for that question. So yeah, these are the subtle clues they often try to give us. And I don't particularly like this, but this is how AMC is. They have some hidden agenda in some of the cases, not in every cases, but in some of the cases, they have this hidden agenda where you ask that particular question that they want you to ask, and then suddenly the case starts going in a different direction because you suddenly find out that it's a different thing that I'm dealing with. Okay, so that question, what she was trying to convey by saying that sleep makes it better. Okay, I couldn't figure out what she was trying to say, but one thing that happened after that was when she kept saying that, I asked her, I asked her about stress. Is anything making you stressed? I don't know why I asked that question when she kept telling me that when she sleeps, then it gets better. But I just felt like maybe there is some stress going on in her life. And then I asked her, is there anything stressful going in your life? And she said, no. And I think, fortunately, I asked another question. Has there been any stress in your life at any point of time, any stressful event? By asking that, I was trying to ask about PTSD, and then she opened up. She opened up and she told me that she had this bullying history in school, and because of that, she became shy, and then she stopped talking to people. Now she cannot make friends, and she does not go out much, and so on. Okay, there is another question. How patients apply ice while wearing cast? So they can wrap it in a cloth and then they can apply it in the swollen part, in the swollen distal part, which is not covered by the cast. This just reduces the blood flow and then reduces the swelling.
Doctor, I have a question.
Yes, please.
One of mentioned about the medicine in the exam, if someone going to ask you the medicine name, so even sometimes simple medicine, you become confused, like whether you should say it or not. So like can we respond in a way that we will give you medicine according to therapeutic guidelines and guided by the consultant? Like don't say any name, just therapeutic guidelines and guided by the consultant. Because when is anyone going to ask you now what medicine, even simple paracetamol will be a question mark for you.
For this, although this did not happen to me, but for this, my strategy, if this had happened, was which I applied in management cases where I had to talk about management. My management, and which we are going to do shortly in migraine case, was whenever I would talk about medicine, I would talk about the mechanism of those medicines, how they would work. So I will give you the medication which will do this. Because for the patient, the most important point is why they are getting the medicine, how the medicine is going to help them. So as an example, let's say that I'm saying that I'm giving them these NSAIDs, then I'll say that I'll give you this medicine, which will help you to control your pain, and it will also reduce your swelling. One thing that the NSAIDs can do, and paracetamol does not do that well, is the swelling, the inflammation part. That is the reason why NSAIDs are more effective when the patient has pain and inflammation both, right? So that's how I would do it. That was my plan. And even for example, because we are going to talk about migraine case shortly. I will not talk about that, but let's say IBD case, inflammatory bowel disease. We have so many medicines there, right? And then these medicines, if you talk about this biologics, how are you going to explain that to the patient? Even remembering the name is difficult. Those immunomodulators, those biologics, their names are quite difficult to remember. So the idea I had in my mind was I thought that I will talk about the salazins, I will talk about the steroids, because steroids is actually, most patients know steroids and they have heard this, this is scary things about a steroid. So I thought that steroid I will mention and I will talk about a steroid, but for the other medications I will simply say that I will give you the other medications which can either control your immunity or lower your immunity, so that it does not keep attacking your own tissues, as that is the reason this happens. And because when you are talking about this, you will be saying that this is something will be done by the specialist, right? So the confusion is, should I say that the patient will be getting this Mumab drugs or this Jumab drugs or all these monoclonal antibodies, should they be mentioned or not? Methotrexate, should it be mentioned or not? Or how should we say it? Basically, this was my approach, although I didn't have to use this. What I would have done is, so we basically, because this is happening because your immunity is becoming overactive, it's attacking your own tissues. So we'll give you the medication which will put your immunity in check or will lower it. But this will be done by the specialist after reviewing that you don't have any conditions in which you should not be getting the medication. And then that means the examiner knows that you know what medication needs to be looked up, right? Basically they want, because everyone will look, I have seen this and you have seen this, that every time people want to prescribe, they look up in memes or they look up in therapeutic guidelines and they get the names from there. So basically they are not expecting us to remember all the names and all the doses. I've also seen that if you, let's say that you if you ask someone from, let's say this what do you say gynecology about the hematological malignancies drug, they will have no idea. And the same applies to, again, people in hematology about the gynecological drugs, because simply now what has happened is everyone is just focusing, specialists are only focusing on what they need to do. They know about their field, they don't know about the others. If they need to, they know that where they need to look up, and that's what they're expecting from us as well, that we know how to find that information. But before searching for that information, I should know what I'm looking for. So before looking for methotrexate or before looking for this let's say trastuzumab in the breast cancer cases. So, I mean, before looking for all these drugs, I first need to know what kind of class of drug I'm looking for, so that I can find out about more information about it. So I don't think not mentioning the name will be a problem, as long as you remember how that medication helps the patient. Even for the patient, it's the same thing.
One more question, doctor. You said that we'll do a follow-up X-ray after 24 hours.
Yes.
So if you are doing telling the red flags, is it necessary to do the follow-up X-ray after 24 hours? Because we are telling the patient that you have any increased pain or any stiffness or anything, just come back. So 24 hours X-ray, is it necessary?
It's just being more cautious.
Okay.
It's just being more cautious. But if you actually ask what happens in the ED, what they usually do is they ask patient to come back in the fracture clinic in 1 week. And in the meantime, if they have any red flags, to come back. But the reason we do it is because ideally we should be out reviewing the patient in 24 hours after applying the cast, and then in the fracture clinic in 1 or 2 weeks. That's why some of the things that we do in the exam are more idealized situation rather than the practical things. Because practically, I think you start taking your shortcuts, you start doing things as you find more comfortable for you. But in the exam, for the sake of uniformity, they want us to follow the standard guidelines and standard ways of doing things. That's why we also say the standard things which we may not do, which we may not find practical enough to do in the real world. If that answers the question.
Thank you so much. Thank you.
So do you need to mention doses for medication? Usually no. The only medication for which you need to remember the doses is adrenaline in anaphylaxis. Otherwise, in most of the other cases, you don't need to remember the doses. You can simply say that I'll be giving the medication, because most of the times either you are using the this automated system built in the medical EMR, or you'll be looking it up. So, and some of the doses, after you start working, after some time, you'll start remembering some of the doses anyway, the ones that you most frequently prescribe. So basically, they don't expect us to know the doses, as it is not as important as, it's not that you have to say the dose immediately. unless it's an emergency drug. That's why adrenaline, you have to remember, because you will not have time to look up the dose and find out how much you need to give. But if someone is, let's say that getting any particular medication, I'm not getting anything in my head right now, then you will have time to look up. Let's say that you are giving a cefalexin to someone, so you want to find out which dose should I give in this case. You can look up and you can tell the patient, or you can write in the prescription after looking up in your EMR or in your whatever system you have in place. Okay, regarding work commitments, what help we can offer? So basically in this case, we can offer the time off work. So we can provide the medical certificate about the time they need to be off the work. And then for that, if needed, work assessment can be done. So you can organize that. You can organize about whether the patient can resume the work after 6 weeks after the cast is removed or not, or if there should be gradual return to work. Gradual return to work is actually patient starts in a new role in their workplace, where their current disability does not prevent them from doing the work they're supposed to do. So basically, let's say that the patient is a typist. Now the person cannot type, but let's say the patient can stay in the reception and then provide some services as some kind of offer. So there will be some transient change in the workplace, but that will be based on the recommendation made by this work assessment. So you can mention that if you know about it or if you feel comfortable enough. So you can ask the patient, so what kind of occupation do you do? And so you may need to make a little change in your occupation for the time being. And if you need that, we'll do that. So yeah, we did not mention bone cancers here because AMC says that it will not be a good idea to alarm the patient unnecessarily, because if you look at the handbook in the IBD case, they have mentioned that, because we know that one of the complications of the IBD is the potential cancer in the future, lymphomas, but they have mentioned that don't talk about this at this stage because patient is still in the stage of doing the investigations and preliminary stage of management. So if we extrapolate that information in the handbook, what it simply means is some of the possibilities are there, but don't talk about them unless you have started doing some investigation. So in this case, for example, if you tell the patient that because you have had fracture, it could be pathological fracture, this can be a bit concerning and we haven't done enough investigation. So you can simply say that it could be because of the thinning of the bone, and we are trying to find out why that may have happened or why your bone has become weak. So one of the possibilities is osteoporosis, but we'll do other investigations to find out other important causes as well. So this is just, it's more of your communication skill. Without alarming the patient, you are also letting the patient that there are possibilities, some possibilities that we are looking into. Because cancer still can be a bit scary, especially for people who have come with minor complaints. If the patient already has some hint of what may have happened, in those cases, in some counseling cases, patients already know what it could be. For example, we have a case of prostate cancer that I'm not sure if we will be able to discuss today. In that case, the patient has already been told that he has prostate cancer by the specialist, but now has come to GP to ask about it. So in that case, patient already knows cancer. So if you say cancer, it is not a bad thing for you to mention. But for others, yeah, you have to be careful. It's very patient specific. So in case of displaced Colles fracture, in case of displaced fractures, we will have to have the orthopedic consultation. So most of the management plan will be made by the orthopedics team. So we can mention the same thing. So non-displaced fractures are usually managed in the ED. There can be orthopedic consultation depending on the extent of damage or extent of fracture. But if it is displaced fracture or if it needs open reduction, then the management plan will be made by the orthopedics team rather than by others. So we can say the same thing. But generally, I think they don't ask us about the displaced fracture because that will be more a specialized case. So maybe that is the reason. Natalia, yes, please.
I would like to ask about cancer you just mentioned. If we suspect cancer, should we tell I suspect cancer in your case or just nasty growth? What is a better
Just say
approach?
cancer. Because
okay, thank you.
Because people have shared this story before as well, that when they said nasty growth, the role player asked, what is a nasty growth? And they had to explain what the nasty growth is. And cancer is not a medical term. Cancer is a layman term, by the way. right?
Okay, thank you very much. Thank
Because
you.
we use the words like malignancies, benign tumors or malignant tumors. So cancer is just a layman word. And you will know when you can say cancer, because the stem will clearly guide you in that direction that you have to talk about cancer now.
Thank you. Thank you.
Jancy has a question. Can we mention about Colles fracture complications? Yes, we can talk about Colles fracture complications, but because the chances of complications in Colles fracture is not as much as in others, I think it's up to you to decide. If you feel like you still have time, then you can mention it. But whenever you are talking about any complications which has lower risk, I mean lower chances, just be careful about not alarming the patient too much. But if you can do it in the right way, then you can mention this. In a very few cases, we can have these kind of complications. We can have this Volkmann's ischemia where the blood supply might be compromised, and then you can have this contracture. So you can talk about that, but be careful when you are doing it. You will be able to decide these things in the exam. A lot of the times, based on patient's response or how the conversation is going, you'll be able to do it. Most of the time, I think most of the time in the exam, I felt like how I did in the exam was more of a reflex rather than how I had prepared. And I think your reflex becomes more attuned the more you practice in that particular way again and again. Once you start becoming habituated in doing things in a particular way in the exam, regardless of how things are asked, you will be able to do it in the right way. So that is one of the reasons why we do role plays, so that we keep doing things in the same way again and again. But otherwise, the exam happens under so much stress and with so much rush that you don't get much time to think about, it could be this and I will do it in this way. It's just more of a reflex response. Patient says something, you immediately come up with something and you answer, if that makes sense. So if it's all right, we can move to the next case. We have, I think, migraine and prostate cancer left. Migraine was booked by, let me just quickly check the name.
I'm here. I'm Dr. Salma. I do want to do this
Salma.
migraine one. Yeah, okay.
I tried to reply you earlier, but for some reason it was saying that
No
you are
worries,
not
yeah.
in the meeting.
Yeah, sorry. Yeah, I was late.
That's all right. Yeah, we can do migraine if you're ready now.
Yeah, I'm ready.
Okay. Let me find the case first. Okay, can you see the case now?
Yeah, I can see that.
Okay, I'm going to start 1 minute timer now. Let's start now.
Okay, right. Hello, this is Dr. Salma, one of the doctor working here today. So how may I address you?
Hello, doctor. My name is Julia.
Julia, nice to meet you, Julia. So, Julia, may I know that actually what is your concern today?
I have been having this headache for so long, so we have done so many investigations, and still they have not found anything. So yeah.
All right, I'm so sorry to hear about that, Julia. Don't worry, you are in safe hand. I'll try my best to give you the best possible care. All right. So,
Okay.
Julia, okay, all right. As I have come to know from the notes that you are having this kind of attack for last 13 years, right?
Yes.
And almost all months you do have this headache. And also there are lots of investigations you have done and they revealed no abnormality. That's a good thing, right? So here, before we start our conversation today, would you tell me any particular concern that you do have that I should be addressed?
Now I'm worried that it might be a brain tumor because I have read so much about brain tumor, and
Oh,
I have little kids, so I'm really worried.
I'm sorry. Yeah, you were thinking that way. Don't worry, you were in safe hand. Okay, but let me assure that as we have already have seen about your symptoms and the imaging test that has been done of your brain, and it reveals normal. So the chance of having the brain tumor is less likely, but still, I would like to tell you the possibilities of this case. Okay, just don't get stress yourself. All right.
Sure.
So here, Julia, I seeing your symptoms and also considering the other things, the most likely condition that you might have, we call it the migraine. So I'm sorry for using this medical jargon, but I do know actually what is migraine is.
I've heard about it. My mom also had it.
Okay, yeah, that's nice to hear. Okay. So, okay, I'm just making these things to clear to you. This migraine is kind of headache, okay? So in this kind of headache, you might have these symptoms of like having the headache by one side of the head. Sometimes it is kind of thunderclamping, or sometimes it is throbbing like pain. Sometimes you might have this pain one or more than two, or sometimes the 3 times per month, okay? And also there could be some predisposing factor, like if you might have some strong sensation or any zigzag line or any flashback, just a bright light before starting the pain, okay? And also that can be associated with the vomiting sometimes. So considering your symptoms and just having the reports, and suspecting that you are having this, well, that could be the other chances as well. Okay, are you there with me?
Yes.
Okay, so but there could be the other chances as well, like sometimes yes, you are concerned about the tumor that you might have in your brain, but the brain tumor might be associated with some symptoms that is specific for that, like this early morning nausea or vomiting. Sometimes there is any numbness or weakness on any side of the body, the problem with the vision, that can also be present in this kind of brain tumor. But I'm just letting you assure that don't worry about that, as already we have done with the imaging test and it reveals normal. So I can make sure that no, there is no chance of having this brain tumor. So are you there with me?
Yes.
Okay. So just let me talk to this migraine. Well, this migraine, actually the cause of the migraine is not known yet, but sometimes we assume that there could be some predisposing factor that can trigger, sometimes that can trigger this condition. Might be that could be the fatigue, sometimes the hunger, sometimes the strong odor or loud noise. Sometimes if there is any hormonal changes, okay, and certain kind of foods like the cheesy food, also the coffee and chocolates can trigger these symptoms. That means this migraine. So here, as you did have this almost 4 occasions headache, and that were preceded by gradual appearance of a shimmering zigzag line that enlarged, moved to the peripheral visual field, and also faded over 45 minutes. So here I am going for migraine more likely. Okay, are you there with me?
Yes.
Okay, so here we can just plan about some management. Okay, so that you might have some comfort and can get relief of this kind of headache. So usually here we do plan for the treatment, like this is the this sometimes this migraine is kind of mild, okay, it can be moderate and it can be severe. So here for mild attack, you usually prescribe the paracetamol that will help you to get relief from the pain. And also if there is any vomiting episode, then we can also add the antiemetic that will also reduce the vomiting as well. Okay.
Okay.
And also sometimes it is not subsided by the simple paracetamol. We can add the aspirin, that is a medication that will also help you to get relief from this headache. Are you there with me?
Yes.
Okay, all right. So if there is if your headache is not responded to this aspirin or paracetamol, then we can do plan for the next option that might be the sometimes we call it, that might be the naproxen, that means the strong NSAID. That will have also some anti-inflammatory effect as well as the killing the pain. Okay, and also if it is not responded to this naproxen, then we can go for this next one that is known as the ergotamine. Okay, and also sometimes this triptan.
Okay.
So these are the drugs usually used for the more severe cases of migraine.
Okay.
Okay. So here also we can go for some lifestyle modification to work as a preventive attack, like just try to avoid the triggering factor. Also, you can adopt a healthy lifestyle that will include you to follow some relaxation technique, that might be the medication, sometimes the free hand exercise, also the yoga as well. And if you get 3 or more attacks, okay, in 1 month, we'll also start with the preventive medication, like the propranolol that is used for this prevention of the migraine. But before we prescribe this propranolol, we would like to ask the patient that whether the patient is any history of any asthma. So do you have any kind of history of asthma?
No, doctor, I don't have any asthma.
Okay, that's great. So here also, so do you want me to focus on anything? I mean, anything else that you have particular concern on any other thing else?
Is there anything else I need to know, doctor?
Well, right now, as we are planning for getting relief of your pain from this attack also, so also the lifestyle modification, and I will follow you up after 1 month
Okay,
after
time out.
following this medication and the lifestyle modification. Okay.
Okay, your time is
Okay.
over.
All right. Thank you so much. Okay.
Very good. You covered all the important points, all the important key points in migraine. So it was good. So you started by asking about concerns. You asked about expectations. You asked about concerns. You asked about trigger. You told me about triggers. You talked about management. So most of the important points were discussed. Now, what are the things we can do to make it more personalized counseling for the patient? That's what I'm going to discuss now. Now, some of you are saying that in the chat, we should stop OCP. Is this patient taking OCP?
No, I don't think so. No history of OCD. Is that so?
So we have not
No.
discussed that, right? We
Yeah.
don't know. If you look at this TAME, do you see OCP anywhere? No. And if you look carefully,
No.
it says more common during menstrual bleeding.
Yeah.
So it's hormone related migraine. Usually that is
Yes.
associated with menstrual bleeding, right? And if the patient is on OCP, usually the OCP associated migraine happens when the patient's hormonal pills are over and they are in the withdrawal phase because the estrogen level drops and then they have this headache, right? But how would you know this? So this is the reason in the beginning I said that in counseling cases, we have this assumption that we should not be asking anything to the patient, but how can I ask someone to do something without knowing their situation first? Yes, I cannot ask history. Yes, I cannot ask about all the questions about the personal history or family history or so on. But there are certain things I'll have to ask. And one good thing in your counseling was when you told me about preventative medication, you didn't simply say there are preventative medications. You said that you have 1 to 3 attacks. So I think it's a good idea to start preventative medication. You offered me one option that was propranolol, and then you asked me whether I have any asthma so that you could rule out contraindication. Now, I think this is what we need to do in each step. Does it make sense what I'm trying to say?
Yeah.
So in every step. Now, I think this will be our last case. So I think we will be wrapping up our discussion with this important message that in counseling cases, important thing is you are not giving information to the patient because that information they can read on the reading materials that you will give them. You are telling patient according to their condition what they need to know, what is important for them. That's why most of the counseling stations become challenging for people, because in counseling, it's not just about telling what the options are, it's about telling the patient what is more relevant to their case, in addition to giving them the information of the general situations. So in this case, for example, how can we make it more personalized? I was writing this when you were doing your presentation. So you asked me about concerns. Very good. You asked me about that. That's why you could address that as well. Not all the counseling stations are similar. The previous two counseling station, Colles fracture and the AAA, we were told about the diagnosis, right? We knew the diagnosis. In AAA case, patient had that incidental finding, so they didn't have any concerns about that, other than the concern that they came up with one problem and they now have another problem to deal with, which is more urgent. That was their concern. That's why we mostly focused on that. We mostly focused on the surgery, letting their family members know, taking care of people at home, because suddenly they have now this big thing on their way. And the second one, the most important point, was this patient now has minimal trauma fracture, will not be able to use one hand. But as some of you rightly raised the issue that why this patient had the fracture, minimal trauma fracture, why the patient had minimal trauma fracture, and what the patient is going to do about daily activities. Let's say if the case had fall, then we would have asked about fall, how the patient had that fall, because in counseling we'll have to address those issues, like if they had fall because of vision issues, because of joint issues, or because of, let's say, hearing issues, because of any medications, we would have to do our review, or our counseling would depend on that. So we are not taking history, we are just asking the relevant points so that we can tell them what would be the right thing for them to do. So basically, in this case also, if we look at the history, what it is saying is this has been happening for 13 years, which is not a short time. So 13 years, 1 to 3. So if you think about this STEM, there are a few key points that this STEM is asking you to include in your counseling. First is it's happening for a long time. That means patient may have already tried some medications. So when you are talking about the medication option, you could have asked about that in the counseling part. So have you used any medications in the past and have they worked for you? Why the issue has not been solved for 13 years? What has happened in the 13 years, right? That would help you in finding out what would be the best option to offer to the patient, or what would be the possible options to offer to the patient. Maybe the patient has already tried NSAIDs, maybe the patient has already tried paracetamol, but I'll come to that point later. So concerns, you asked about concerns, very good. You can also ask expectation, because in this case, expectation is very important. 13 years, 1 to 3 attacks per month, disabling attack going on for so long. So an MRI has already been done, everything is normal. So what is her expectation in this visit? What is one thing that she wants you to do? Concern, she has shared that it could be the brain tumor. So what expectation? Is there anything you are expecting from this visit? Is there anything you want me to do? That you can ask in questions like this. That's one. And I think the other one was, I think, just a slip of tongue. What happened was, I told you that my mom also had migraine. You asked me, do you know about migraine? I said, yes, my mom also has it. And then you said, nice to hear that, which I think was just a slip of tongue. I think you were trying to say that you were trying to say nice to hear that on the point that I know about migraine, but it felt more like you said nice to hear that because my mom also has migraine.
Exactly. I was supposed to say, I'm sorry to hear about that.
Yeah. So you said nice to hear that. And yeah, I just couldn't help but notice that. Yeah.
Yeah, it is a slip of tongue, exactly.
Yeah. And so you were asking me, are you with me? Which is a good way to engage the patient. But as I said, are you with me is a routine question. What you can do is, you were telling me about the triggers. So you mentioned that the triggers are this, this, and this. And then you could have asked me, do you think you have any of these triggers? Do you think your migraine is triggered by any of these things? Have you noticed any association with that? She has already mentioned about menstrual bleeding there. And so she might tell about something like, okay, yeah, sometimes when I eat chocolate, it happens, or when I drink coffee, then it happens. Then in your counseling later on, you can say that, yeah, chocolate and coffee often are associated with this, along with this factor. So maybe you can avoid them. So this way, it becomes a two-way conversation. Do you agree? What do you think about that?
Yeah.
Okay, and then you address the point about brain tumor, which was very good. I think that was an important point in the history that if you had not asked me, I would not have told you about that. And then that point would have been overlooked. And then um, for candidates who would fail, they would just be wondering, like, did everything about migraine. Why did I fail? Because you did not ask about my concern. And I never told you because I was instructed not to tell you until you asked me. And because you did not address my concern, that means you have not done the main task, important task, right? So you asked me that and you explained that to me. And then again, just an additional point, when you were talking to me about the brain tumor and you told me that you don't have any of these symptoms, but if at any time you feel like you have any of these symptoms, we can always talk about this and revisit your symptoms and do more investigation. This way you are assuring the patient that we are not dismissing the concern. We are simply saying for now we don't have anything to pursue it further. So that assures the patient more, I think. And about the management, I already talked about that point, that because she has had the issue for so long, it will be a good idea to ask if she has been using any medication or not, if there is anything that helps her. Or if not, we can move up to the next medicine. And because in the management, one of the management option, especially in the first line drug, is antiemetics. It will be a good idea to ask if she also gets nauseous when she has these attacks, as we can prescribe antiemetics. And the other thing is, in some of the patients whom this NSAIDs alone or paracetamol alone is not working, even though they don't have any nausea, we can still prescribe them these antiemetics, especially metoclopramide, because it improves the absorption of the drug, as it's a prokinetic drug. So it helps in the movement of the drug to the part where it is absorbed. So absorption is better. So this metoclopramide, especially out of all the antiemetics we give, has the added advantage of improving the absorption of other drugs as well. So that's one thing that we can ask, and then we can decide later on. So if you have nausea, then we can use this medication. If you have any kind of vomiting, that's one. Lifestyle modification part, you discussed that, which was good. And preventative medicine, you told me about propranolol. You can talk about the other possible options as well. So basically, this is your performance, I think, was quite good. And just these are the additional points that you can add. Now, let me quickly show you what I have prepared. Now, regarding why migraine happens or how migraine happens, in the past, we used to think that it happens because of the dilatation of blood vessels in the brain, but now we have come up with this new theory. But I think explaining this to the patient can be quite difficult. Still, it's here, and because I'll be uploading this as well. So if you want to explain this, if you think you can remember and explain this to patient in a simple way, you can do this. Otherwise, you can still use the same one, like it happens because of the dilatation of the blood vessels in the brain. But this is the more acceptable, more widely accepted theory right now, the trigeminal theory, which simply says that it's because of the activation of the nerve cells, and that leads to the release of substance P, and that causes this widespread inflammation, and that causes the contractions and migraine. But I think explaining this to the patient is not that easy. After that, commonality, as we had discussed earlier, we can mention that migraine is quite common, and it tends to happen usually in the younger adults, can also happen in children. But as people become older, the frequency starts decreasing. So this perhaps will be one of the things that you can mention, because she has been having this for 13 years. So this will be something relevant for her to know, that it usually the frequency decreases with increasing age. Cause and triggers, you have already mentioned all of this. Fatigue, stress, and this will be more important for us when we'll be talking about the management, where we'll have to tell the patient that they need to avoid the triggers as much as they can identify the triggers. That is the reason we want to ask them about the triggers, if they have noticed any association between any particular things leading to their migraine. Now, clinical features, we don't really need to explain this to the patient other than the fact that she has headache. But if we want, we can ask them about if she gets any aura or any prodrome before her attack starts. Why do you want to ask that question again? Because again, in counseling case, you are asking questions not for the diagnosis, you are asking question to tell them some advice, some suggestions that might help them. The reason you're asking this about aura and prodrome is one of the non-pharmacological management of migraine is you go to a quiet room, you go to a dark room, you lie down, and that helps you with your headache. So if you get aura or prodrome, you know it's going to happen. So let's say that you are about to leave for your office and you have this. Now you know that you are going to have headache. So that means it gives you the clue that this is time for you to, maybe change your plan and do something less stressful or less exhausting, so that you don't need to abort it in the middle of doing it. So that is the reason you can ask this question. Again, I don't need to explain these things to you. I think most of you already know what happens. So we can have this program where people can have the symptoms sometimes up to 48 hours before the attack starts, like increased yawning, suddenly they become very hungry, or their mood starts changing, especially if it's a hormone related migraine. It's almost like those menopausal symptoms people have. So mood changes, that can happen at 24 to 48 hours before the attack happens. And then during, just a few hours before during, they can have aura, typical or atypical aura. And then when the headache starts, you have also explained about the headache and what happens when the headache starts. Again, it's not related to the counseling case, but just letting you know that one of the cases, headache case in our exam is this thunderclap headache. And the thunderclap headache can be because of the subarachnoid hemorrhage, and thunderclap headache can also happen in migraine. And one confusing thing is thunderclap headache of subarachnoid hemorrhage actually responds to sumatriptan, as migraine responds to sumatriptan. So this will be more important in history taking cases when you are doing the history taking for headache. So I think keeping this in mind perhaps will help you in the exam, that one of the differentials still will be this subarachnoid hemorrhage, and the other one will be migraine if someone is complaining of this thunderclap headache. And if in this time they say that sumatriptan was given and it's responding, you will still suspect subarachnoid hemorrhage, because even subarachnoid hemorrhage responds to the sumatriptan to some extent. So regarding the program, this is again important for your counseling, because after the attack, patient will feel exhausted, tired, weak, hungry. So you will have to let them that when that happens, they need to take proper rest, because otherwise it increases the risk of another attack. That's why they need to know this, what happens after the attack and how that can be the trigger for another attack. So basically about the management of acute attack, the non-pharmacological management is you rest in a quiet room, you avoid any movement, you do not use any stimulating activities, you do not do any stimulating activities, and you can apply cold packs to head. That helps. This is one of the non-pharmacological method mentioned in therapeutic guidelines, that you can apply these cold packs to head when you have the attack, or when the attack is about to start. When you have this aura and you know that it's about to start, you can do this. And if you know that you are going to have migraine now, because people who have migraine, they know in advance most of the times now it's going to happen, they can take medication when they feel that they are going to have the attack, rather than waiting for the attack. So that is the reason why we talked about those prodrome and we talked about aura, because you know it's going to happen, you can start taking the medication. That's what the principle of taking this preventative medication as well, right? Because if you're having too frequent attacks, you have to take it. Regarding the medications themselves, you can mention some of the names. They expect you to mention some of the names, but you don't need to go into the details. At least you should be able to say first line medication is this, and if it does not increase, if it does not address the problem, then we can change the medication. But the most important point for you to mention to the patient is, whenever we try any medication, we have to try them for a couple of weeks before we switch to another medications. So before we try in a couple of attacks and we see how the patient responds to that. If the patient partially responds every time but not fully, that means we need to switch to another. If the patient does not respond at all in 2-3 times, then you need to switch to another. But you have to do it at least a couple of times. And the other thing is, if the patient is taking the pain medications because the attacks are frequent and they are taking more than 15 days in a month, then also they need to come back to you. Okay, they even if in addition to, let's say a patient is in preventative medication and they have had these attacks despite that, or patient is not in a preventative medication and they have had attacks, and if this has happened more than 15 days, that means now there is a risk of this pain medication overuse headache. So because you know that if someone is using painkillers for too often, then also that can lead to medication overuse headache. So you have to tell the patient that although you should be taking this, if you if you find yourself taking these medications for more than 15 days in a month, that means it's time for us to review the medication and find you something more suitable, because otherwise it increases the risk of having the headache caused by the medications themselves. And then go up to second lines. You can mention some of this, and you can say that we have got the second line medications. If this doesn't work, we call them triptans or argot derivatives, and they come in, these triptans come in oral form or injections and intranasal, but we'll discuss them if needed in the future. We'll discuss them in more detail. In this patient's case, once we ask the patient if they have used any medication or not, or if they have used medication in a more systematic manner or not, if they have tried any preventative medication or not, after that, if we find that if they have been using and still they have not been responding, then we can talk about second line. Otherwise, the reasons they are called second line is because we have to try the first line and then only we move on to that, right? So we'll talk about the first line and then we'll only mention the second line. If they don't work, we have this. But here, the only reason we are mentioning the second line is it's to let the examiner know that we know about that. And the reason I have included this in this slide is because in handbook, they have mentioned that candidates are not expected to know everything about these drugs and their doses, but they should know the options, which means they want us to mention this. That's the reason why I included them here. Preventative therapy, as you have already mentioned, first is the lifestyle modification here, and then second is the medication. So for the lifestyle modification, avoid the triggers, make sure that you are not too exhausted or too stressed, and those SNAP protocol like no, don't smoke, eat healthy, be active, avoid alcohol. That applies to almost all the patients in AMC, so you can include that. Preventative medication, when we use it, if the patient has more than 2 attacks in a month, and this patient 1 to 3 attacks, that's why she was eligible for that. And you rightly mentioned that, which is a good thing. And if you are using preventative medication, to find out whether it is working or not, you have to try it for at least 3 months before you switch to another. So you try patient on 3 months. So what that means is once you put the patient on medication, you have to tell them that if you don't have any pain or if everything is under control, I'll review in 3 months. Otherwise, if you have any red flag symptoms, then you can come back to me and then we can review a case. So the review time, you can keep as 3 months to see the response to the medication. And these are some of the options for the preventative medication you can mention, but you don't need to get into the details of this. If you mention 1 or 2, like beta blockers and calcium channel blockers, I think it should be all right. Medications like tricyclic antidepressants, methotrexate, they have more side effects. So if you are mentioning this, what you can do is, rather than saying we have this beta blockers, pizotifen, and then talking about their side effects, which I think is impractical, what you can simply say is, we generally do not use these medications without proper indications, as they come with side effects. If we need to use them, I'll make sure that you do not have any condition that prevent their use. And depending on the medication used, I'll have to follow you up and different tests to review your side effects. Something like this. You'll just simply mention to them that we don't usually put patients on preventative medications because of the side effects they have. And we have to make sure that you don't have any contraindication to their use. Once we put you on these medications, we'll have a different follow-up plan where we'll have to review you in a timely manner to see if you have developed any side effects. Generally, we will do it every 3 months. That will be your counseling points. And as I said, in every counseling case, think if there are any ancillary health services you can use. And in this case, and this is evidence-based, they have seen that if the patient feels tightness in their neck, then they can be referred to physiotherapist for the neck stretching exercises. So this is one thing, again, you can include in asking, do you feel like your neck becomes tight during the attack? And then if that is the case, I think you will benefit from a physiotherapist referral. So generally, when you will decide whether or not you are going to do the referral for these patients, if the patients have any neurological symptoms, headache is getting worse and worse, or they are not able to function in their daily activities, then they only have aura and no headache, then in such cases, then you do the referral. But do you need to say this to the patient or not? No, not everything. You will tell patients if your headache is not getting better, if you are becoming more worried about having these attacks, if it's limiting your daily activities, or if you start having any weakness of your limbs, then in that case, you can come back to me, or you can go to the nearest hospital for the treatment. So that's how you can talk about this. So basically, in counseling cases, rather than using the same format of counseling in all the cases, I think if you make two different formats, one for interpretations of investigations and the other for explanation of different conditions, I think it will be more useful. Also try to personalize the counseling based on patient's situation. And when you are moving from one part of the counseling topic to another part, I mean that when you have explained the condition and you want to move to the clinical features, for example, just make sure that you ask something to the patient so that you can engage with the patient in a conversation, and your counseling, rest of the parts of the counseling will be based on that. That way the examiner will be able to see that you're not just simply regurgitating the information, you're actually using the information you have to help the patient. And basically that's what it is about. Now, I have heard people saying that empathy doesn't help in the exam. Depends on what you understand when someone says empathy. Empathy is not just saying, I'm sorry to hear that. Oh, I'm really sorry to hear that. Are you with me so far? Have I answered your question? These are just the routine questions. And even AMC examiners know that people are asking these questions even in places where they perhaps don't need to. Empathy means being engaged with the patient and asking them things which are relevant for you to help them. As in our cases, we have seen that asking that patient of the fracture whether they have someone to help at home, or in case of AAA, asking that patient if they want to call someone here because we have suddenly told them that they will have to stay in the hospital, or in this case, asking the patient if they have used any medications and if they have helped or not, or if how it is affecting their life, and then or asking about the concerns in the beginning. These kind of things are what we call we mean. These are the things that we mean when we say empathy. So basically, including empathy is not about saying sorry or saying thank you or just asking follow-up questions. It's about making sure that you engage with the patient. That's my understanding. Again, we all are working in our fields, and we have all been working for so long, I think. So you all have your opinions, and you are welcome to disagree with me. But this is my understanding, and I think this is how it should be. Now, I don't think we'll have time to discuss other cases. Again, as usual, I would expect your feedback on this because whether or not we do another session depends on how many of you will be interested in this and how many of you benefited from this. If you feel that this is something we should be doing more often, please let me know. I'll be more than happy. This also helps me to become more expressive, and I love doing this. That's one of the reasons I do this, because I've been teaching for almost 18 years now. So I love teaching. But if there is any suggestion for me, any feedback for me, please let me know. And if there are any cases that you want to discuss, let me know. If you feel that it has not been that helpful, again, let me know, because everything helps me to decide what we should do next. And if you have any questions, let's discuss them. And after that, we'll wrap up. If you have a question, please feel free to unmute yourself and ask the question. Yes, I'm actually thinking of doing physical examination cases very soon, but we'll have to prioritize which physical examination component we want to do. I mean, which system. Can we refer this patient to headache clinic? Yes, and because we have headache clinic here, especially for patients who has had symptom for this long, referring to them to headache clinic, I think is a good step. CVS, Respi, and Neuro are AMC favorites. Okay, we can pick one of them. What I'll do is on our Facebook group, I'll do a poll, and based on what most of the people pick, I'll go with one of them. And we have not finished all the counseling cases. Actually, there are more than 20 counseling cases. That was not my intention anyway. I just wanted to let you know how it should be done. So we still have 2 more. I will share these slides anyway with you. All the slide information is already on the website. This recording will also be made available on the website, and I'm also planning to record 10-minute long videos of each case with a sample presentation of the counseling cases, so that it will be helpful for you. Hopefully, I'll be able to do it by the end of this week. I have already shared my recalls, by the way. If you go to the Facebook group, and if you scroll down, you'll see that Google Sheet link. If you click on that, you will be able to find those recalls. Vaccination counseling, yes, we can do that. Okay, so I think which Facebook group? So we have a Facebook group called AMC Tutor. Maybe you can ask one of your friends to add you to that group. It's a private group, so you may not be able to find it. I think you can still find it if you search on Facebook. Can we do the last session again? Which last session was that? Jancy is asking, can we do the last session again? Which last session was that? The last class. You mean where we discussed about the overall approach to the exam? Okay, I'll see if we can do that. Okay. So yes, thank you everyone for being here. I hope you all have benefited a little bit with this discussion. Please feel free to engage in discussion on our Facebook group. Share your materials, help each other. This is how we can pass this exam. There is no official guide. There are no reliable sources to use. So basically everyone who has passed so far has passed with the help of other people. So help each other. That's the way to go. And thank you so much for being here for this long. And all the best for your exam if it's coming up. I'm signing out now. Thank you so much. Good night.